BCL2 inhibitors are becoming a major player. We would even go far as to say the backbone potentially of future AML therapies. BCL2 is important in AML, but I actually think it's going to become important in many other diseases. CLL, of course, we know it has a great history and track record. We're also seeing activity in ALL, acute lymphoblastic leukemia. CML, there's a lot of preclinical synergy with dasatinib and other TKIs, and these trials are being looked at. Lymphoma, there's activity, myeloma in particular subsets. So I think that this is going to become, for the heme malignancies, a very, very, very important treatment strategy. AML specifically, we're hoping that the BCL2 to AML will be what the IMiDs were for myeloma. So we think that the azacitidine-venetoclax combination can become a new backbone, but on its own, we don't think it's enough to get away from chemotherapy. Response rates are high, 70%. But if you look at the 3-year survival, it's 45%. Whereas with induction like chemo, especially in the favorable intermediate groups, reports have shown somewhere between 50 to 60, 65%. So I think we need to do more work, but I think we can get to this point where we could replace induction chemo with HMA-VEN. So some of the approaches that are looking at this are combining the new FLT3 inhibitors with HMA and venetoclax, adding gilteritinib and quizartinib to the backbone of azacitidine-venetoclax. We actually have both these studies open at MD Anderson. Initially, they're going to look at the doublets of venetoclax with quizartinib, venetoclax with gilteritinib in the relapse, and then the hope is to move it in the front line using azacitidine, venetoclax, quizartinib, gilteritinib in the FLT3 mutated. If we can hit 70% 3 to 4 year survival, then of course the big question is, why do we want to do induction chemotherapy with FLT3? Let's do the lower intensity with a powerful FLT3 inhibitor. Same approach with IDH1 and 2. In fact, at the EHA this year, my colleague Dr. DiNardo will be presenting data combining IDH inhibitor with the venetoclax, showing even in relapse setting we could get up to 70-80% response rate without chemo, without HMA, which again 5 years ago people would think would be impossible. So that also is moving to the front line, adding IDH inhibitor to hypomethylating venetoclax for IDH mutated. And for those who are not FLT3 or IDH, where we don't have this kind of targeted triplet with HMA venetoclax, we're looking at either idasanutlin or some of the immune therapies, PD-1 inhibitors, monoclonals, to add these to the HMA venetoclax, and these studies are actually ongoing. So we think in the future, for maybe not all AMLs, there are some AMLs that still benefit from chemo, like the core binding factor and others, but for a large proportion, maybe 70, 80, 90%, we hope that there will be triplets that will further improve the azacitidine or decitabine venetoclax to the point where they're equal to chemo, and if that's the case, we would definitely prefer those over the patients. They're much more tolerable, they're outpatient, less early mortality. So I think it's going to be very much like the myeloma field has gone, where they used to do VAD, vincristine Adriamycin dex, only 12, 13 years ago. It's not ancient history, and today, nobody talks about it. It's all about the new molecular targeted immune therapies, and I think finally AML is going to move in that direction.